So the initial management of somebody presenting with symptomatic hyperviscosity is plasmapheresis, plasmapheresis, plasmapheresis. There's no guarantee that any therapy will be able to set in and correct things quickly. So you don't want to waste time. If you're seeing the extent of retinal hemorrhages that we see in this particular case, you got to worry that this patient may be at risk of losing his vision. And in addition, the bleeding isn't just in the eyes. It can be occurring elsewhere, the brain, for instance, and the last thing that we want is for a 42-year-old to lose their vision, but also potentially have a stroke. Plasmapheresis is by far the most important thing for this patient. It would be the correct answer, before initiating or thinking about other types of therapy. So in looking at a case like this, I would be very much inclined to know what the genomics of this individual were. I would be thinking about his age. Given that he's young, I would try to avoid, administering therapy that may have an impact on his future ability to receive therapy, but also putting him at risk for other cancers. I would be looking at the symptoms that we need to address. In this particular case, we need to address the fact that he's got symptomatic hyperviscosity, but he also has bulky adenopathy. That's a game changer, because there are classes of drugs that we use that are good at reducing bulky lymph nodes, and there are classes of drugs that don't. And so being able to balance out the short and long-term goals of this patient becomes really critical. The genomics offer us an opportunity to be able to work into this type of patient, the options for therapy, but also you got to look at the underlying picture. So this individual received bendamustine as their initial therapy. This was predicated on the fact that his genomics had shown both a MYD88 mutation establishing the Waldenström's diagnosis, but also this patient had a CXCR4 mutation. You would expect that in somebody who has symptomatic hyperviscosity, because these are the classical patients that present with high IgM levels and symptomatic hyperviscosity. In his particular case, he actually had a nonsense CXCR4 mutation. This is when a mutation is introduced in the tail of the CXCR4 gene, and this causes cleavage. And this is important because there are many different types of mutations that occur in CXCR4, but the ones that are nonsense are the ones that are associated with very high IgM levels. The problem with that is that if you were to initiate a therapy like a BTK inhibitor, it may take a long time before it actually produces a response. That's not to say that that would not have been appropriate, but in somebody who's already presenting with symptomatic hyperviscosity, you'd want to get control of the disease as quick as possible. Also balancing this out is that when you look at the other classes of therapeutics that you would potentially use, like a proteasome inhibitor, proteasome inhibitors may be good at inducing responses, but not against bulky adenopathy. So that would be another reason why that particular class of drugs would not be appropriate. And we certainly wouldn't use nucleoside analogues, because we know that there's a very high risk of disease transformation and the development of acute leukemia. And this is a very young patient. So again, it's not an option that we would pursue. This is where we start, thinking about what's in the best interest of the patient. Ordinarily, with alkylator drugs, we would want to avoid them because of, potential damage to stem cells and setting the patient up, for other problems down the line. But he's clearly presenting with an oncological emergency, a very, very bad case here, and we need to get immediate disease control. So in this particular case, a drug like bendamustine would be reasonable. Perhaps given his young age, you'd want to be able to keep the number of cycles of therapy to a minimum. We often use 4 cycles of therapy of bendamustine, when we treat, younger patients. And I think in this particular case, this would be very appropriate to do. I would not use rituximab right off the bat, because we all know that rituximab can induce an IgM flare. So even though, the patient underwent plasmapheresis and we got the IgM level down, we would be concerned about using rituximab right off the bat, because it could flare that IgM and we could be back into symptomatic hyperviscosity again. So the right thing to do there is to start the bendamustine therapy, maybe go 1 or 2 cycles until the IgM gets down, particularly under 4,000, and stays down. And then one can add in rituximab in the care of this particular patient.